Hi guys, thank you so much once again for having me. It's an honor. Arsalan Saleem, the residency program director here at University of Texas Medical Branch. I'm also the division chief at UTMB. It's my alma mater. This is where I train as well. The associate professor of interventional radiology here at UTMB. And I will be talking to you guys about percutaneous biliary endoscopy. I was also requested to talk about urinary interventions as well, but I thought for the amount of time that we have and to kind of cover it, make it digestible for all attendees, from medical students to the residents and the faculty, I wanted to focus on this one more. So with that being said, I'm going to start. I want you guys to take a moment and imagine this 90-year-old patient. And believe me, you do get these 90-year-old patients, and interventional radiology is one of the specialties where you will be getting these patients who are geriatric population, don't have any other option available to them. They can't be a good surgical candidate. In this particular example, this 90-year-old lady has chronic cholecystostomy tube with her, and she keeps on coming back for her routine exchanges. And she seems very cachectic, very frustrated with this tube because she has to live with it. She can't get the gallbladder out, and she can't be a good candidate for endoscopy either because it's a little bit too stressful for her. And the only thing she can do now is keep on coming back for these routine exchanges. And then here you go, and you come and you say hi to her and say, you know what, maybe I can offer you something. And maybe I can solve your problem and make you a free bird. And 3 months later, boom, you see her cachectic look is gone. She's very happy. She's seeing you in the clinic, and you're taking her tube out. So um, I'm going to be giving a comprehensive review of percutaneous biliary endoscopy, something which has always been there since 1990s in the realm of interventional radiology, but only now is gaining more wind and popularity in our circle, given the advancements in the technology. So just a brief introduction. It's basically percutaneous biliary endoscopy, where you can do the endoscopy from a percutaneous route into the biliary tree and even the bowel. It's a minimally invasive procedure that enables direct visualization of the biliary tree through a percutaneous approach. It's used when ERCP or surgery is not feasible. We'll get into a little bit more depth of that. Talking about the indication of this procedure. It's complex biliary stone disease, such as oriental cholangitis, biliary strictures, both benign and malignant, biliary leaks and fistulas, retained stones post-ERCP, where GI has failed, biopsy of biliary lesions, where you can't just get to them from endoscopic route from GI side, or even they're not easily approachable from percutaneous route otherwise. Tumor ablation and palliative interventions and biliary tract reconstructions. I can't emphasize enough on this slide, and I think this is the slide I always tell my residents and my medical students is what makes you different, which is the difference between you and a simple plumber and you and a carpenter. Is patient selection. Anybody can learn the procedures and they can start doing these procedures. But what makes the difference is where you know where to do a procedure and when not to do a procedure. And if you are going to be doing a procedure, make sure that this patient is the right patient for doing the procedure. So good patient selection is key to success for any service line. May it be IO, interventional, venous procedures, arterial procedure, anything. So these patients, the ones which are good candidates for these procedures, are actually non-surgical candidates. These are post-transplant patients who have already had a major surgery. They have frozen abdomen. There have multiple adhesions there. Surgeons don't want to go back in, open them up. Difficult or unfavorable post-surgical anatomy, such as Roux-en-Y and gastrectomy. Here you can see the picture of a Roux-en-Y gastric bypass, where it's very difficult for the GI to go in and actually be able to maneuver back into the duodenum and get into the biliary tree. And if the GI has failed, for example, large 15 millimeter impacted stones, intrahepatic bile duct stones that cannot be managed by standard ERCP techniques, where there has been migration or occlusion of biliary stents or duodenal stents, which are migrated in front of the biliary entrance where GI cannot get back in. And management of recurrent pyogenic cholangitis, also known as oriental cholangitis, where there's multiple stones and large stone burden in the entire biliary tree, and PCS, primary sclerosis and cholangitis and strictures. So just to talk about a little bit for pre-procedure clinic visit and workup for these procedures, the most important thing is that you set the expectation right with your patient. You want to make sure that, yes, you're going to be offering them an option, an opportunity which they thought they did not have, but at the same time, you want to make sure that they know how this is going to work out. It's not a one and done procedure. Most of these procedures, most of these patients will need multiple dilations, multiple stage procedures, stone removals, and also talk to them about the fact they're going to be under moderate sedation and or MAC with anesthesia present in the room. They're not going to be under general anesthesia. That's the first. That's the reason why they can't get their gallbladder out or some other complex surgery. And also make sure that you have all the imaging that you need. For example, MRCP, ultrasound, CT. Get the lay of the land in the battlefield. You want to know what you're dealing with before you even get in there. Get your pre-procedure antibiotics ready for this patient, know what their allergies are, their coagulation status, their medical status, and all of that, just like any other pre-procedure workup. I'm going to talk quickly about the procedure itself. What does it really entail? It actually starts from the very get-go when you first get the consult for an acute cholangitis and acute cholecystitis. So we're going to talk about percutaneous access, the tract dilation over the course of the disease process and your management, and cholangioscopy itself, and then the different interventions that you can offer and techniques, and then how do you close and complete the drainage procedure for the patient. So talking a little bit about percutaneous access. I know, we all know, if you pick up any book for interventional radiology, any literature, all talk about transhepatic approach to be a better approach than the transperitoneal approach. It is, of course, safer. It is going to be more safer in terms of vitality of the tube, in terms of when the patients go home, if they're going to get pulled back easily or not, and also the leakage and bleeding profile. However, if you are planning on doing you already kind of have an idea this patient is not going to be a good surgical candidate, and you're planning on doing Spyglass in future, getting a percutaneous transperitoneal approach where you hit the fundus directly in line with the longitudinal axis of the gallbladder is actually something which is very good, because once you go back with your Spyglass and your scope, you get the full view of the entire house right from the entrance, and you don't have to make any U-turns and do all these different aerobic stance moves inside the gallbladder, which will become way more difficult for you to get the completion and get all the stones out. And go big or go home. If of course, with the patient's overall picture and the position of the gallbladder and or the liver and the biliary tree, if you can go bigger safely, you put the bigger tube right there and then, so you don't have to do multiple dilations later down the line. These are a few diagrams for what I was mentioning before, the transhepatic approach and the transperitoneal approach. And if you are doing the transperitoneal approach, try to get in line with the longitudinal axis of the gallbladder. It'll make your life easy later down the line. Tract dilation. These patients have to come back for multiple tract dilations if you could only place a smaller tube, and or if it was a different size tube. The end goal is to get to 16 French, according to what we do here at UTMB. That's your final goal. And of course, how many times the patient is going to come back every 1 to 2 weeks, it depends highly upon patient factors. How much can they tolerate the pain? What's their availability and also their body habitus? Take your time. You want to make sure it's been 6 to 8 weeks. Your tract is mature before you do your intervention with the scope. There's no urgency in these patients. These are not emergent patients. You've already taken care of the urgency and emergency by placing a tube at the first place. And the cholangioscopy. Once you're doing cholangioscopy, your choice of access across the track is very important. It highly depends upon what you're trying to achieve. If you're trying to do biopsy, you're trying to take gallbladder stones out, you're trying to take the stones out of the biliary tree. Each different scenario has different access instrument that is the most favorable for those situations. For example, Medcom peels, peel-away sheets. These are the ones which you can easily use for a gallbladder initial sweep and initial um, sweep with your scope, and then you can start taking the stones out afterwards by cutting the sheath or opening the sheath up so it can flush back. Cook 16 and 18 vascular sheaths, they're very good to have the really controlled and continued inflation of the biliary tree and gallbladder or the biliary ducts. Or if you're wanting to do ablation, you're wanting to do biopsy or reconstruction, because you want that area to be inflated enough for your scope to be giving you the view. Otherwise, if you have an open sheath or the fluid is going away, you won't have that level of inflation or the view at the first place. Cook Amplat's renal dilation set. I will be showing some pictures as well. We actually go all the way up to 30 French, especially for instances where the gallbladder is only the culprit and there are multiple stones in there, multiple small tiny stones. And once you put the 30 French in, all you need to do is flush them all out, and the procedure is literally 10 to 20 minutes long, and the whole gallbladder is clean. But of course, it comes with some experience, and as you feel more comfortable and your center proceduralists feel more comfortable, start doing bigger sizes one by one. And then the simple 12 French Boston Scientific Spyglass sheath, which comes with the set, that's the one you can just use for doing diagnostic sweeps before with low suspicion of pathology, where you're going to be making them tube free. And before you do that, just do a small quick sweep. And these are the Cook 16 French sheets or 18 French sheets, the ones we use in the Medcom peel-away sheets. And this is the Amplat's renal dilation set, which the urologists use for their kidney stone retrievals. They also go all the way to 30 French very easily and very safely. And believe me, kidney is way more vascular and dangerous of a organ when it comes to dilations and whatnot. And if they are doing it safely, we can do it in the biliary tree as well. Interventions, of course, we just talked about stone removal, stricture dilation, tumor ablation. There's a whole list of them. I'll need a separate lecture for that, but there are multiple techniques that can be used for these procedures as well. The 2 points I really want to highlight on this slide is we never go beyond 2 to 3 hours per session for these patients. It doesn't matter what is the stone burden, how hard was the stone to break and take them out. We will bring them back in small sessions, because why? We have already set the expectation right with our patient, and there's no urgency, no emergency. So take your time, do a good job. It may be multiple procedures, but you will eventually make them tube free. And second point, we have started using forceps, the same forceps that we use for IVC filter removal. If our dilation of the tract can be achieved to 22 French and more, we've been using forceps retrievals, because sometimes these stones are just so hard they can't be broken by some EHL probes. And to get the forceps and take them out with a bigger sheath, the procedure time just decreases, and it's a faster recovery for the patient as well. Closure and drainage. If you've completely made your patient stone free and your patient's ready to be taking this tube out, even then, always leave the drain in there, because the system inside the biliary tree, the gallbladder, is still kind of irritated and inflamed with your intervention. Leave the tube in there, bring them back in 1 week, cap it, bring them back in another week with repeat labs, make sure nothing's blocking in there, you didn't leave anything behind, or something was hidden, and then you can do your cholangiogram, remove the tubes. Patients who we have already dilated to higher levels, we do leave bigger drains in them, but we bring them back quicker, because you don't want to send them home with bigger drains for a longer amount of time, like 20 French or 22 French Tal and gore drains. Usually once we made the patient tube free, our follow-up looks like this: 1 week, 6 months, and then yearly follow-up with the labs. If in case of patients who have oriental cholangitis, or they have, and during the course of treatment over a couple of weeks to months, we saw that these patients kept on forming soft gallstones around the tubes, the ones which we're leaving behind. We do put them on ursodiol starting with 3 milligram TDS, and we can go up to 900 milligram TDS for per patient. Why we keep bringing these patients back, even if we have done them make them tube free? Guys, we are the image-guided surgeons. The day we realize that as a specialty, that's the game changer. They are your patients, and you are the main driver of the longitudinal biliary care for them. Okay, believe me, even the GI stop seeing these patients. We should not stop seeing these patients. We should keep an eye on these patients, take ownership of our patients, keep bringing them back on regular routine follow-ups with repeat labs, and see how they're doing. Extra clinical applications would be difficult G to GJ conversions and biliary and CBD reconstructions. We've started doing CBD reconstruction where surgically the CBD is gone, or avascular necrosis of the CBD. We've been reconstructing 5 to 6 centimeters of the CBD now. And I think one of our medical students is going to be sharing a case report of one of our CBD reconstructions as well during this conference. So real quick, advantages and limitations. You can do direct visualization, useful in altered surgical anatomy, and it bridges the gap in the care for non-surgical candidates and patients. We have our own hashtag tube free. With the permission of the patient, we put it out there. What are the limitations of these procedures? And these are, of course, going to be more invasive than the simple ERCP, and potential complications like any other IR procedure: bleeding, infection, bile leaks, and pancreatitis. However, on our review of our single center experience, the complication rate has been way less than 1%, and less than that of the ERCP. We also did a review of TriNetX database, which was available to us with all the biliary and endoscopic procedures be done by interventional radiologists or the surgeons, and compared with ERCP. And even on that review, I think we're writing it up, and we're going to be submitting it to SIR, so JVIR, for publication, and we presented it in the last SIR as well. The complication rate, including pancreatitis, bleeding, infection, is way less than the ERCP. Most of the time, because we are better and more comfortable with these axes, and number two, the angle with which we are going in with our intervention is actually not against the biliary, the pancreatic duct. So chances of having pancreatitis are way less. And of course, with more experience, you're going to get more expertise. This slide is the most important slide, which I want to focus on the most. It's the service line development. How do you develop a service line? Holds true for any other service line as well. So guys, it's all about precision medicine, meeting the unmet need with a laser focus on longitudinal care. So these 3 points: precision medicine, you're meeting the unmet need, and you have to be someone who's providing longitudinal care. If you start thinking like that, you start walking like that, you start moving like that, you start talking like that, and then there will be no turf in any of your service lines. Every patient that you touch is your patient, and you intervene upon, you place a drain on, it's your patient. Follow them up in your clinic in 4 to 6 weeks. Get in the driver's seat. Okay, you should be the one. A lot of times we're seeing patients who have not followed up with their surgeons because of the fear of surgery or whatever reason. But they do come and see you. You should be the one making sure that you made sure that they're not surgical candidates. You're the one who's the main traffic controller. Your colleagues will start respecting you. Most of these patients have no other option. So if you're going to be a full clinician, this is going to be amazing for these patients. And last but not the least, start making multidisciplinary teams and approaches in your basic framework. We here at UTMB, we have weekly pancreatic biliary conference that we started, and we have different specialties in our group in this meeting, and we call our group BILE. We submitted different acronyms for that, and the one which we have gone with is the one with biliary interventions and learning enthusiasts. And who is amongst in our team? Of course, GI, our trauma and acute care surgery, interventional radiology, and transplant surgery. And all of us sit together on a weekly basis, discuss these difficult cases, and it will further enhance your clinic and your patient population. What are the future trends? They're making much more smaller scopes, so miniaturization of these scopes and angioscopy with the same scope, and AI-based biliary navigation system, which can help you doing further oncologic interventions for malignancies as well. Um, our team, when Ahsan Riaz came down to UTMB about 3 years ago, ever since then, it's been a great journey, and it's been a great history to write. And we are second highest volume in the country right now for biliary endoscopies. In conclusion, percutaneous biliary endoscopy is a valuable tool, and for a lot of complex biliary conditions for which there was no other option in the past, but now we can offer that in collaboration with other specialties. I'm open to any questions. I hope I was able to cover as much as I can, but there's more I would like to talk about, and I think we've been talking to Joji, and we're planning on some lectures for sure.
Thanks so much, Dr. Saleem. This was a great talk, super comprehensive and covered all the things that are like music to our ears. I think that just about wraps up the hepatobiliary and oncologic section. But if there's any questions in the chat, please feel free to leave them there. And attendings, if you're able to just look at the chat for any questions, that would be great. And then we'll be moving into a quick break before we start our next section. Thank you guys so much for all of your
Thank you.
time.
Thank you very much.